So, very good evening to all of you. Once again, welcome back everyone for the 50th edition of the this month endoscopy. So this is a achievement for this month endoscopy group, and we have achieved this golden jubilee edition. And we thank our previous eminent panelists and speaker to everyone. And this time also we have two eminent panelists, and we are honored to have them here. We have our own, who needs no introduction, our own Dr. D. Nageshwar Reddy sir, who is the past WEO president, who is the Padma Shri, Padma Bhushana, Padma Vibhushana, every awardee of our India. He is our pride. So welcome, sir, to 50th edition of this month in TME. And we have with us Padma Shri Dr. T.S. Chandrasekhar, and he's the current ACG governor also. Welcome, sir, to the 50th edition of this month endoscopy. So we are honored. We got two of you here for this edition, and we have Dr. Sridhar Sundaram, professor in the Department of Gastroenterology, TMH, Mumbai. He has taken pen to select three beautiful articles for this month edition. So over to you, Sridhar, to start the proceedings.
Thank you, Manas. Thank you. I'll just share my slides. So a very good evening to one and all. And once again, I'd like to thank both our esteemed panelists, Nagi sir and TSC sir, for having spared their time from their busy schedules and making it for this occasion. So this is the 50th edition, and of course we could not have done this without the effort of all Chalapati, Manas, Nitin, and Avinash, of course, who was there with us previously. So I'm going to be discussing three articles today. First is going to be on cryoprevention for post-ERCP pancreatitis. The second is going to be ESD versus TAMIS for rectal lesions. And the third is going to be regenerative endoscopy for difficult GI defects. So this is the first article that I'm going to be discussing. This is local post-procedural cryoprevention significantly reduces the incidence of post-ERCP pancreatitis. It's a multi-center randomized trial from Japan, recently published in the Red Journal. So we all know that the current guidelines recommend rectal administration of NSAIDs for prevention of PEP. And of course, there is a lot of data also on combination of various therapies involving NSAIDs for reducing the risk of PEP. But then again, in Japan, rectal NSAIDs are not approved for PEP prophylaxis under the National Health Insurance Scheme. It's very expensive. Also, the formulation available in Japan is limited to 50 milligrams and the recommended dose is 100 milligrams. So there is a significant hesitation for the use of rectal NSAIDs in Japan, and which is why they look at alternative modalities for prevention of PEP. So cryoprevention using ice, of course, we know for soft tissue injuries, there's a lot of data available, and it's known to induce vasoconstriction and reduce metabolic activity and reducing edema, which may reduce similarly the edema at the papilla and lower the risk of PEP. And this same group has published a single center prospective study demonstrating positive results. They use the historical cohort of 100 patients and 100 cases. They use cryoprevention, and they shown a 7% difference between the study group and the historical control group. Now, of course, the aim of this study was to evaluate whether irrigation of the duodenal papilla with ice water at the end of ERCP could reduce the incidence of PEP. So this is a multi-center patient-blinded randomized controlled trial. It's called the Utopia trial. It was performed at 8 hospitals across Japan and between March 2022 and February 2024. And eligible patients aged over 20 years or older with native papilla were included. Now, of course, exclusion were those with poor ECOG, age less than 20 years, if the papilla was inaccessible, post-operative reconstruction, acute pancreatitis, chronic pancreatitis, and also pancreatic head cancer. Now, why they were reduced, they were not included was CP and pancreatic head cancer are known to have a lower risk of PP as compared to standard patients. And of course, the inability to provide consent. So randomization was done in a 1:1 manner with block randomization. And it was done immediately pre-procedure. So, I mean, dropout of patient was, of course, less because it was done pre-procedure. Now, cryoprevention was performed after completing the ERCP by irrigating 250 ml of ice water towards the papilla in 550 ml aliquots using a syringe. Now, to prevent the aspiration of irrigated water, after each 50 ml irrigation of ice water, the fluid was aspirated and then irrigation was repeated 5 times. And the scope was removed without aspirating the final bolus. And the total procedure time was around 2 minutes after the procedure. And no NSAIDs were administered in this study. So the primary outcome was incidence of PEP. Again, they used the Cotton criteria for defining it. The secondary outcomes were safety outcomes, cholangitis, bleeding, perforation, and mortality. Now, they also did subgroup analysis for difficult cannulation, various ERCP procedures, for pancreatic duct cannulation, pancreatography, cannulation time, the moderate and severe PEP, and PEP by high risk factors of PEP. So sample size, now based on their previous study, there was almost a 63% relative risk reduction is what they found. And based on that, assuming the baseline risk was around 10%, for a 50% reduction, they should have around 440 patients in each group is what they thought. So this is the consort. So you can see 880 patients were randomized, 443 in the control group, 437 in the ice water group, and 3 actually withdrew consent, and which is why ice water was given only to 434 patients. Now, if you look at patient characteristics, the funny thing is that, of course, the age, you can actually see a lot of nonagenarians in the range, and of course, some over 100 years also. The median was 74, 75. So this is Japan. I'm sure, they live a lot longer. The only thing I found out was the median is 74, 75, but more than 60 year, the percentage was actually lower. So maybe a typo, 16%, 18%, that needs to be checked. Of course, if you look at indications, it was largely stone disease and a few malignant biliary strictures. So around 85 to 90% were actually stone and malignant strictures. Coming to details of the procedures, again, if you look at successful ratio of biliary cannulation, it was almost 98, 97%. But if you look at inadvertent PD cannulation, it was pretty high, around 38% in both groups. Again, high risk were 83, 84% of this category. And important is pancreatic stent placement was done in a very small proportion of patients, only 7.8 and 6.5% in ice, water, and control groups. And trainee involvement, if you look at these hospitals, they were all training centers, and clearly trainees were involved in almost 65% of all procedures that were done. Now, if you look at primary outcome, PEP occurred in 14 patients, that is 3.2% in the ice water group, and 30 patients, 6.8% in the control group. And there was a relative risk reduction of 52% and an absolute risk reduction by 3.6 percentage points. So the number needed to treat was around 28 to reduce one incidence of PEP. Now, the incidence of moderate to severe was also 0.7% in the control group and 1.4 in the ice water group, but there was no difference in the groups. If you look at the secondary outcomes, safety outcomes, there was really no difference between the groups either. Now, important is the subgroup analysis. Now, if you look at age more than 60 years, again, there was a difference in both the groups, ice water doing better. In those with high risk of PP, again, ice water fared better. In those with difficult cannulation, ice water fared better. But the funny thing is, in those who underwent a pancreatic stent placement, there was no impact of the ice water on the risk of pancreatitis. So clearly, it is in high risk groups, but if you're putting a pancreatic stent, it didn't actually have an impact. So coming to the discussion, of course, NSAIDs are the current standard we all know, but this is a rather simple method of PP reduction. Significant benefit in this RCT. Now, we know that combination stent with NSAIDs is better than NSAIDs alone. But again, in this trial, they showed that once a stent was placed, the risk did not, change significantly with the ice water or no ice water. Now, if you look at the limitations, of course, they did not use NSAIDs at all, which is again the current standard. NSAIDs are rather cheap in India, so we are using NSAIDs left, right, center for all our ERCPs. Again, they did not do any irrigation in the control group. They could have maybe done it in room temperature water also. Now, again, 250 ml, there is really no scientific basis for it. We don't know if they would have done it maybe 2 times, 5 times, 10 times. Does it change the risk of PP? That's unclear. Again, there is no double blinding. Again, that was not possible. And clearly, they based their hypothesis on a 10% risk of PP. But even in the control group, it was only about 6.8%. So again, lower than expected baseline incidence of PP was seen. So clearly, there is need for more comparative studies between the existing standard of care and the new technique. So to conclude, the author stated that an innovative method for PP prevention, so it's cryoprevention with ice water, This technique is safe, simple, and cost effective, and can be implemented by any physician involved in ERCP without the need for any pharmacological agents or specialized equipment. So this is the graphical abstract and clearly significant decrease. So over to the panelists, I think Nagi sir and TSC sir.
Sir, you are mute, sir.
Thank you, Sridhar, for that very nice presentation. I think this is a very important paper and deserves a little discussion, because I think the importance of this paper is the simplicity with which they did it to prevent pancreatitis. Of course, limitations you discussed very well. Indomethacin was not used, and this is a major limitation that's going to become an issue. Now, several years back, we published a paper, Nitin would know this, where we used epinephrine, adrenaline mixed with noradrenaline mixed with saline, infused on the papilla, and a very large series, almost 2,000 patients randomized to both groups, in which it was a multi-center study led by Venkat. And we found that there's no difference between both the groups in terms of decreasing the incidence. Now, the principle of using epinephrine was that it also causes constriction of the vessels and produces the same effect as ice water, but we found no effect. We are not sure what is the difference between that and this, but I believe that we don't understand the basic pathophysiology of how this actually prevents. It can't be just constriction of the vessels and decreasing the inflammation, decreasing the edema and all that. There must be some other mechanism, because vasoconstriction is not doing it, so there's some other mechanism. So in addition to the limitations you said, I think the important limitation is that they shouldn't have actually injected directly with a 50 ml syringe. They could have actually put smaller amounts of cold water using a cannula directly injected onto the papilla. Because when injecting 50 ml, it's a large volume, and each time you have to aspirate, it takes time. So if they used a cannula and even put in 20 ml, slowly infused on the papilla, that would have probably produced the same effect. We have to, I think, try this along with epinephrine. Rectal indomethacin, does it decrease the incidence? So this is a very important point, I think, because already our post-ERCP pancreatitis is coming to about 3% on average using indomethacin. So can we reduce it further by using this technique? And I think this is a very easy study to duplicate. My suggestion is that we should get together in a multi-center fashion in our country and see if we can use it in a modified fashion along with the indomethacin to decrease. Then you're talking about 1% post-ERCP pancreatitis, which would be very, very good. So that would be my comments on this. Yeah.
Right. TSC, sir?
I think Nagi almost summarized it. Necessity is the mother of invention. So what Japanese inability to use the the drugs like all the indomethacin, probably they were forced to use an alternative method. So we are left now, our proven methods are only the indomethacin and pancreatic stenting. This looks much, much simpler method. We really don't understand pathophysiology. So first we see the effect is good. Why this effect is happening, we can study. We can do some study on the in vitro study, how the slow installation of the cold water. As Nagi suggested, right, that we should do the multi-centric study. It is very simple, doable, and hundreds of cases we are doing every day or across the India. So I think you have chosen a very nice study. I must congratulate for this. Here, you don't have to even get I don't know about ethical issues, you need to get it because non-pharmacological.
Yeah, clearly, yeah.
Clearly, that is a great advantage of this. Only thing is we need to analyze the statistical data, how much it is comparable to the. So you must have at least the 2-arm study, you need to have that. Either the regular indomethacin and stenting or cold water and stenting, and like that we have to do that. So we need to discuss, form a panel, and we should discuss about this. That will be very interesting actually. And it is very cost effective and hardly take 2-3 minutes.
Right, very true, sir. Very true. Only thing, I mean, like Nagi sir suggested, we are looking at maybe a 3%, 3 to 4% incidence of pancreatitis across the board. So the sample size is going to be required is going to be very high. So clearly, I think a multi-center in Indian initiative makes sense. So maybe
I agree with Nagi, 3%. There are centers who do less frequently, can be more also.
Yeah.
And
Yes.
one pancreatitis bad case can be really challenging to the treating unit. So as you want to bring it down more and more, it's a welcome only.
Right, sir.
And I think actually we need some calculations, Sridhar. I think we may require approximately 5,000 cases, at least 2,500 in each arm to get. But also, I think when we do this study, we should add cold water and regular normal saline in one arm. Actually, 3 arm would be better, but statistically it becomes problem.
Right.
Nothing normal saline and cold saline, but it will be difficult statistically. But if we can expand our base to a very large number, so probably if you do 7,000 cases, then we can do 3 arm using all these 3 methods.
Right, sir. Right. Manas, Nitin, any comments?
So yes, Manas.
Yes, please go ahead, Nitin.
So as Dr. Reddy has already pointed out, if you are using 50 ml per each time, and I think that they did it for 5 times, so eventually you'll require 15 minutes of additional anesthesia for the patient. Changing that protocol to injecting via cannula directly onto the papilla would reduce that time. So that and then we can plan the study.
Right. I mean, we are anyway using a cannula for the ERCP, so it's just spraying additional fluid. Manas?
My comments, Sridhar, as sir suggested, this is a simple one, doable, and I hope if we take multi-center one, any number can be doable in India. And
Right, very true.
so this is a simple technique. We are not doing anything extra here. So just with a cannula, cold water is a simple one. So we can replicate this study. Whether it is feasible or not feasible, we can see that.
Right. I think SP sir is also SP sir. Any comments?
Same thing. I just wanted to make a point that our incidence in this country of pancreatitis is less. And like Nagi said, it's about 2-3% or 4%. So we need a large sample. Secondly, they're infusing for a very long time. Aspiration may be a problem. And then rectal suppositories are so simple. They're simpler than this. They have a problem with rectal suppository. We don't have a problem with rectal suppository. So that's another angle to be taken. Secondly, in those who they have put a pancreatic stent, the incidence was the same.
Right.
So that subgroup has to be taken care of. If you put in a pancreatic stent, then this cold water doesn't work. And if we can make a device, Nagi can do it, that we can place something which is cold over there, irrigation or something sort, and on the papilla. That may be more helpful than putting in water.
Thanks, sir.
I am thinking, SP, this is a good idea. Why not we the prophylactic pancreatic stents we put in a refrigerator and then put it when you are actually doing that? No?
I don't think I wonder they don't know the mechanism, whether it was just at the papilla or putting inside the total duodenum worked.
Yeah,
so that has to be only at the papilla, or logically it should be papilla, but it may be the entire duodenum.
Yeah, so actually this is again you can do very easily experimentally the mice model. Put induce pancreatitis and put on the papillary surface, and also inject small amount of cold saline into the pancreatic duct and see what happens.
Right.
Anyway, this is a new opening for many of us.
Secondly, Nagi, you have opened up a Pandora's box. Why don't we have chilled dyes?
Yeah, that's a good point. I think that's a very good point, using a chill dye also to see what happens compared with the regular standard contrast.
So, nice discussion. Thank you very much, sir. And so we can go ahead, Sridhar, for second presentation.
Thank you. So the second article I'm going to be discussing is this randomized control trial comparing ESD versus transanal minimally invasive surgery. That's the TAMIS in early rectal neoplasm. This is the DESTAMIS 2018 study from Spain. It's a multi-center Spanish study published in Gastroenterology recently. So we all know early rectal neoplasms, of course, they can be adenomas or they can be T1 adenocarcinomas. And of course, if they have favorable histopathologic features, they are amenable to curative endoscopic or local excision with excellent long-term prognosis. Now, even when we are doing an endoscopic evaluation, of course, the absence of deep despite there being absence of deep submucosal invasion on our endoscopic evaluation, rectal lesions are known to have covert submucosal invasive cancer, and which is why doing something en bloc and doing something more aggressive always works better for these tumors. So local resection techniques that enable en bloc resection should be prioritized for, of course, precise histopathologic assessment, maximizing curative potential, and of course to spare unnecessary surgery. So the aim of the study was a head-to-head randomized control trial was designed, adopting a non-inferiority design with the hypothesis that ESD may offer lower morbidity, shorter hospitalization, and reduced overall costs, while potentially providing oncologic control equivalent to TAMIS. So the method is a randomized non-inferiority open-label multi-center clinical trial with a parallel 1:1 design. The study timeline is between April 2019 and December 2023. Study setting is 3 Spanish tertiary university hospitals in Madrid, Barcelona. There are 2 in Madrid and 1 in Barcelona. So the inclusion criteria: patients more than 18 years of age without uncorrectable coagulopathy. Again, presence of a non-sessile lesion or flat lesion more than 20 millimeters in diameter. It has to be located 3 to 14 centimeters from the external anal margin. So nothing too low, nothing too high. The circumferential involvement should be less than 50%. There should be no clinical suspicion of deep submucosal invasion after undergoing an imaging study. So it can be either an endoscopic ultrasound or a pelvic MRI. Again, exclusion criteria was, a background diagnosis of IBD, pregnancy, severe anorectal fibrosis from a previous surgery. If it was a LST granular homogeneous type of lesion, wherein of course the risk of invasion is very low. Any lesion with more than 50 millimeter with suspected advanced histology on endoscopic assessment, wherein it was JNET3 or CUDO 5N. And of course, synchronous neoplasms requiring, radical rectal surgical treatment, regardless of the local resection. So again, it was a 1:1 randomization. It's an open label study. Now, TAMIS was done under GA in lithotomy position, and a TAMIS approved port, either the SILS one from Medtronic or which again we also use, and the gel point path was introduced. And it was a similar mechanism. It's a similar technique like an ESD. So a minimum experience of 10 cases was needed for the surgeon to be part of the trial. Now, ESD was either done under GA or TIVA. Minimum experience was 30 cases with at least 5 rectal ESDs. Now, admission was done for 1 day for all patients after the procedure, and follow-up was done at 1, 3, 6, and 12 months. If you look at outcome measures, the primary outcome was the rate of local recurrence at 12 months post-procedure after the initial resection. And again, secondary outcomes were the technical success rate, wherein we were able to remove the tumor. En bloc resection rate, R0 is considered wherein you have more than 10 millimeters from more than 1 millimeter from the base, the distance of the tumor. And of course, horizontal margins also should be negative. Now, curative resection and expanded curative resection is based on the R0 resection criteria again, but expanded would be any negative margin is considered expanded curative resection. Procedure time, early local recurrence rate, hospital stay, and complications, of course, classified as early and late. Now, the cost analysis was also done as per the Spanish National Health Program. Now, the hypothesis, again, the sample size was based on the hypothesis that the local recurrence was 2.5%. With a non-inferiority margin of 10%. So the required sample was around 34 patients, accounting for a 10% dropout. So coming to the results, this is again the consort. 185 patients were assessed for eligibility. There were quite a few actually who declined to participate also. 22 directly wanted ESD, 4 wanted TAMIS. So 73 were randomly allocated, 39 to ESD group, 34 to TAMIS group. Again, eventually after randomization, there were 33 and 37 in the ESD arm. Now, in the TAMIS, there was some amount of crossover. 6 patients actually crossed over to the ESD arm because it was not feasible or patient preference after randomization. So again, if you look at per protocol analysis, it was 43 ESD and 27 in the TAMIS group. So if you look at the baseline characteristics, around 60 years of age, a significant proportion of male, 60%. But the important thing is the lesion size. If you look at overall lesion size, is around 38 millimeters. But the lesion size was slightly larger in the ESD group. Again, if you look at 35 with standard deviation of 11. Here it's 40 to 26, so it's slightly bigger. Again, if you look at morphology, I think the numbers were skewed. I think there is some typo here, wherein the numbers are not matching in the percentages, but it was largely LST, granular mixed type of lesions that were done. Now, if you look at distance from anal verge, this is again very critical because TAMIS, there is a certain distance that is required from the anal verge for them to actually operate. So it was around 6.9, so 7 centimeters from the anal verge was what was standard. Now, of all those who underwent ESD, if you look at the details, 38% was actually done under sedation without any general anesthesia. Final histopathology, there were 10 patients who had adenocarcinoma on the biopsy, not adenoma with dysplasia, but only 3 fulfilled criteria for a curative local resection. No salvage surgery was offered for any of these patients, but the supplementary details actually said that 4 patients received additional chemoradiation. Now, if you look at the primary outcome, there was only 2 recurrences seen during a 12-month follow-up, both early within 6 months in the TAMIS group. Now, differences in the long-term local recurrence between the TAMIS and ESD arms were not significant in the in the intention to treat and the per protocol analysis. Median follow-up was around 15 months, and estimated survival was, overall survival was 100% in both the groups at 6 months, and again at 12 months it was slightly lower in the TAMIS group. So again, the graph actually showed that there was no risk difference, and it's actually fitting into the non-inferiority margin. So ESD, I mean, they were able to achieve the primary outcome that they actually aimed at. Coming to the secondary outcomes, this is where it becomes interesting because the technical success again for ESD was a lot higher. If you look at it, 100% in both the ITT and the per protocol analysis, it was lower for TAMIS. Again, if you go by the R0, it is slightly different, but I go by the expanded R0. Expanded R0, again, it is significant for ESD is better than TAMIS is what was shown. Again, for curative resection, expanded criteria, you'll find that ESD was better. Only thing, slightly time, there was a difference, 20 to 30 minutes more for an ESD as compared to TAMIS. Hospital stay was much lower for an ESD. Complications did not differ significantly. There were 2 bleeds in the TAMIS group and two perforations in the ESD, all managed locally. None of the patients were actually sent for radical surgery. Now, again, in the cost analysis, ESD fared to have a lower cost on both the intention to treat and the per protocol analysis. Now, coming to the discussion, this is clearly the first comparative randomized trial showing ESD as non-inferior to TAMIS. Now, important things is that of those who are eligible, now there were 22 patients who did not want to come into the trial. So 18 actually chose ESD over TAMIS because they felt it was less invasive, while 4 chose TAMIS because they felt it was more comprehensive. Now, the problem here is that the inclusion and exclusion criteria that they've used for the trial was, hypothetically favorable for TAMIS. So clearly, you can do ESD even for circumferential lesions, and you can do it for lesions extending right from the anal verge till 15-20 centimeters as well. So that is a restrictive criteria. Again, if you look at this restrictive criteria, it led to exclusion of a considerable number of patients who were eligible for local resection. And of these, 7 cases actually had more than 50% involvement, who were in the range between 3 to 14 centimeters, and they were all treated with ESD successfully. Now, again, like I already pointed out, the size of the ESD lesions was unintentionally bigger than TAMIS is what they are saying, but all ESD was completed successfully, while 3 TAMIS were changed to conventional transanal excision and 3 TAMIS to ESD. So again, R0 is based on an arbitrary 1 mm margin criteria is what I think all of us have been taught. But if you look at the expanded R0, in both cases, ESD was scoring over TAMIS. Now, argument typically what most surgeons will give for TAMIS is that they are able to do a full thickness resection. But again, we have modifications for ESD that are available now. So we are able to do an endoscopic intermuscular dissection and also an endoscopic full thickness resection. And again, they were able to show that even in Spain, ESD was lower, but in India, I think the cost considerations are different. Maybe surgery will be cheaper. I don't know. So if you look at the strength, this is the first RCT on this topic with a simple randomization. Now, limitation sample size is based on a previous limited data. Again, the non-inferiority margin was rather wide. Now, open label design, of course, which is why, of course, they could not do blinding because the interventions were such. But then again, follow-up was done by multiple endoscopics and not by the PI alone. So there was no interpretation bias of recurrence that can happen at 6 and 12 months. So to conclude, the authors say that ESD appears to be non-inferior to TAMIS for local resection of endoscopic rectal lesions based on 12-month recurrence rates. And both techniques exhibit favorable safety profiles. Now, compared to TAMIS, ESD is associated with fewer technical constraints, a higher procedural success rate, reduced hospitalization, lower overall cost, and greater patient acceptance. So this is again the graphical abstract of this, which is summarizing the whole thing in detail. So ESD appears to be non-inferior to TAMIS in the 12-month local recurrence rate. Again, over to Sir, your comments.
No, I think this is a good study because we never had a randomized study in this setting. And we always have an argument with our surgeons. In fact, if there's a suitable case, which is say 5 to 7 centimeters away from the anal verge, the surgeons would, if they go to the surgeons, they would do TAMIS compared to if they come to us. But my contention is that this what they set as a, I think first of all the numbers are very low. I don't know whether statistically significant numbers they choose, but again difficult to get large numbers, but the numbers were low. So maybe it should have been a larger number to show a clear-cut difference. The second problem is, I think, the technical expertise. They said 5 cases of ESD in the rectum they could do ESD.
30 total, sir. 30 total and 5 rectal.
Yeah, which I don't know whether what is the learning curve for ESD whether is okay because TAMIS learning curve is much less.
Yeah.
For ESD, I think a little longer learning curve is needed. That's my feeling because I've seen TAMIS being done. They don't inject. The difference is they don't inject something. We do. They just slip it up and then cut. So technically, it's much easier, lesser learning curve than when you do an ESD actually. Because ESD, I think certainly 30 and 5 from rectum is a smaller number as a learning curve. So if you compare somebody who's very good at ESD, maybe the difference would think. But I think nevertheless, it shows that we have an argument now with the surgeon saying good ESD is good or better, so we should do these cases ourselves. Yeah.
So I can before TSC sir says actually this was a bone of contention. I think there was a recent GI Oncology Society conference at Kochi.
Yeah.
And there was a rectal cancer workshop, and this was kind of a bone of contention. I spoke on endoscopic resection, followed by my own surgeon from TMH on surgical resection. And we've both been at loggerheads for quite some time. And of course, we couldn't reach a consensus even there. So I'm sure this is again an issue.
Yeah, so we have the same problem, but again, it's very difficult to argue with GB, So, now we have an article. So, yeah.
I think.
Last point, I agree, Nagi. Very difficult to debate with GB Rao. One thing about ESD, I feel, even though technically demanding, that appears to be a very comprehensive approach for such lesions.
Right.
Compared to TAMIS, I think to large extent this is under vision, and we see that what we are doing. So the person who is good at doing ESD will definitely score over. May now non-inferior may become superior also. One. Number two, the rectal lesion, the numbers we are not going to get in bulk unless you do multi-center. Here they have done it from 3 centers. In India, I think all cancer centers put together, they can get more numbers if you want. So whether we can reproduce non-inferiority from superior, then that will be a good choice for us to start this year. But mind that of all ESD, rectal ESD is easier to do. In fact, everyone says that you start your ESD procedures from rectum.
Right. Very true, sir. Very true.
And after that, only anterior stomach wall, something like that. Last one to do is that duodenum. In that score, rectal would be easier. Okay?
Right. Absolutely.
We need to have multi-center study for a large volume.
Right. I think Manas, SP sir, Nitin, any comments?
So to me, especially Sridhar, to me, this sort of debate or I don't take on, my take on will be our patient is the priority, and whichever method, if your expertise with ESD and go ahead with ESD, and some issue in this advanced technique or something, then you can always call our surgeon colleague to go ahead with this. And there is no matter of debate or something to my perception is that, and our main goal should be the R0 resection or patient should be better. That is my take on.
Right. Nitin,
So
SP sir?
Manas, the debate was basically for the benefit of the patient, not for our benefit. So one thing is that the advantage with endoscope is we have flexibility.
Right.
That's important. Number two, with robotics coming in, what Nagi said, we can pick up the mucosa and operate like the surgeons. Very soon we'll be getting robotic accessories, and that may probably help us more than. And I think ESD will be better than TAMIS.
Right. I think Chalapati wanted to.
Yeah, great paper and presentation, Sridhar. So previously, as a beginners, we used to actually call for and counsel patients for rescue surgery. Like, look, if we are not able to do a good job, sometimes you need a surgery and all. Probably it's the other way around. Like, given technical success, even in expert centers, 90% technical success in TAMIS and 100% technical success in ESD. So probably they should start saying that rescue endoscopy is a possible option if TAMIS doesn't happen.
Right.
No, they didn't realize at that time that the resection was not complete. So that was a problem. It was an afterthought.
Okay. Nitin, any comments? I think.
But Sridhar, I have a question. Why couldn't they complete in 10% of patients? Given we always think that they have the triangulation, they have the traction devices and all better equipment. So what do you feel? Why couldn't they complete in 10% of cases?
So in 6 patients, they've written crossover. Now, they've not given details, of course. They've written that in 3 patients, they've gone ahead and done a conventional transanal excision, that is surgical, not with the lab port that they do TAMIS. And in another 3, they've sent for ESD. Now, I am rather unclear on why that should happen. But it may have been too low or too high, which is why access may have been difficult, is what I feel. That they must have felt that the lesion is significantly, So typically, our surgeons would say 2 to 8 centimeters is their domain. Anything about 8, 9. So if my surgeon very categorically says, if my finger doesn't reach it, I will not be able to do it. So is what he says. So he feels his finger is maybe 8, 9 centimeters, and if he's not able to reach it, that technically means it's either us or major surgery. So maybe that must have been the case, because here it's 3 to 14. 14 is quite high. So I feel that is again a problem.
Sridhar, we can go ahead with the third one because sir is busy in meeting most probably.
Yeah.
Busy, he will be. That's why we have to finish in time.
Yes. So this is again a small study. This is, I think we have Gautam also here, who's done some cases. So I thought we can hear from him. So this is about regenerative endoscopy for the treatment of difficult gastrointestinal defects. It's a result from a pilot trial, published in Endoscopy recently. Now, so clearly we know that there is no standardized treatment. We all do what is favorable to us: clips, loops, suturing, all of that. And chronic defects are, of course, very challenging because of fibrosis and ineffectiveness of various techniques like suturing, stenting, and other procedures. So the idea of the study is based on the endoscopic delivery of stromal vascular fraction obtained by a mechanical emulsification of autologous adipose tissue. So it's basically to regenerate and revitalize the fibrotic tissue with various kinds of stem cells, and it has anti-inflammatory and regenerative tissue promoting effects. And clearly with no risk to the patient and no additional production costs, extremely rich in mesenchymal stromal cells. So the aim of this pilot study is to evaluate the effectiveness and results of endoscopic injection for the treatment of esophageal and rectal defects. So this is a prospective single-center pilot study from October 2020 to June 2024 in Rome, Italy. They looked at 30 consecutive patients with esophageal or rectal defects that were treated with this TSVF injection. And again, inclusion was GI defects accessible by endoscopy, for which all traditional conservative surgical treatments have failed or were excluded. And exclusion criteria were patients not providing consent. So both the endoscopy and the harvesting of the stromal vascular fraction from the adipose tissue was performed simultaneously. Now the SVF was obtained by harvesting 30 ml of fat from the superficial layer of subcutaneous tissue. They used a microcannula with 4 1 mm holes to harvest the microfat from the abdomen. Again, it was, once it was obtained, it was centrifuged, and after mechanical emulsification of the harvested microfat by sequential passage through multiple nanofilters, which was again a disposable filtering device which is freely available. And after whatever they got, the endoscopy was performed to inject 1 to 2 ml of this SVF into the submucosa of 4 quadrants of the defect borders using a 20 to 22 gauge endoscopic needle to complete defect closure. Now, for large diameter defects, that is more than 5 millimeters, what they did was they sutured prior to injection so as to approximate the margins as close as possible, rather than rather than just closure using an overstitch suturing system. So the primary outcome was complete defect resolution at endoscopic or radiologic follow-up. Secondary outcome was the number of days needed for resolution, number of treatment required, any complications related to procedure, and any recurrence 60 days after resolution. Now, again, of course, it was given the rarity of the disease and Julius's statement for pilot studies, which standard says 12 is enough for sample size. As a sample size, they chose 30 as a random sample size. So again, this is what they are able to see. They are able to see mesenchymal stromal cells, and you're able to actually stain the alpha actin, which is green. This is the alpha actin, and again smooth muscle actin. And again, if you do immunofluorescence, again you're able to see the alpha actin. So it works rather well. Now they also showed images of various defects that they closed. This is an esophageal defect, and again these 2 rectal defects. So if you look at the results, there were 15 esophageal defects and 15 rectal defects. Again, location was varied, but the important thing is that a lot of patients have actually received previous treatment for this kind of a GI defect. So there were 40% in the esophageal one and 46% in the rectal one. Now, important is this, time between the acute event and the treatment. It was median was 90 days for esophageal and 170 days, almost 6 months for rectal defects. Now, closure after the first treatment. So after the first injection, 66% in the esophageal small defects, they were able to close. In rectal defects, it was 40%. Endoscopic suturing was additionally required for 33%, 5 patients in esophageal and 10 patients in rectal. Now, again, closure after 2 treatments was very high for esophageal, almost 93%. For rectal, it was 46%. And again, they required 3 to 4 treatments for rectal, and again, the closure was only in 60%. Now, if there was communication with the urinary tract, which was seen in 9 cases of the rectal, defect, the closure was 55%, and with other organs, it was 66%. The median procedure time was around 45 minutes. There was again no major complications or recurrence after closure. So again, we know that there are various techniques for closure available, but problem again, there's long hospitalization, advanced scale complication cost. So this is rather cheap. This is very simple, promotes healing through anti-inflammatory pro-angiogenic processes. The main advantage is its affordability, absence of any tissue rejection. Again, no need for a cell factory or enzymatic agents. The collection, extraction, and endoscopic administration can be done in the same session. And multiple sessions can be done in some cases where tissue improvements are visible after the first 2 sessions. Now, the same group also published this data in fistulizing Crohn's disease, in 10 cases, in 12 cases, wherein in 10 cases, they were able to actually show benefit in fistulizing Crohn's, and they were able to show that 83% benefit with, of course, concomitant biologics. So again, this is another area where this can be explored. Now, the limitation, of course, this is a single center, small sample size. There is heterogeneity of cases, and of course, you need suturing in some cases. So comparative, again, there are various other techniques also under evaluation. There are allogenic stem cell injections that are being done in some studies. Biomaterials being used again so clearly you need comparative studies to know which one is actually very, very good. So they gave an algorithm. So if you look at the algorithm, diameter less than 5 millimeters, you can directly harvest and inject. And again, more than 5 millimeters, you do suturing in addition. And you can review at 7 to 15 days and at 60 days. If it's persistent, again, you can do the same thing for small defects, but again, you need suturing, for larger defects, which they say are more than 5 millimeters. If it's persistent and there is really no evidence of tissue regeneration, that is diameter reduction or improved vascularization, you can maybe stop it. But if there is some evidence to say it is improving, maybe you can continue for 3 or 4 sessions. So to conclude, the authors say the proposed technique seemed effective for treating complex conditions such as esophageal and rectal defects, especially for those communicating with organs other than the urinary tract. Again, urinary tract, the data was rather poor. Now, considering these results, it is plausible to suggest that it could play a relevant role in managing defects accessible by endoscopy. Of course, subject to further standardization and validation with larger studies. So again, this was the overall graphical abstract, and you can see for esophageal defects, the treatment was rather effective. For rectal, it was not so much. So over to again our panelists.
We have Dr. Gautam with us. He will do some short presentation, like 1 or 2 minutes.
Should I stop sharing and maybe he wants to share?
Welcome.
Yes, sir. I would like to share.
Yeah, I'm just stopping.
Can you see my screen, sir?
Yeah, we can.
Yes.
Yeah.
Thanks.
Yeah. So thank you, sir, for setting this up. So we actually, Dr. Valerio, who is one of the second author in the study you have just discussed, Dr. Sridhar, he has visited us recently, and we have started the regenerative endoscopy program in our unit now. We have done more than 10 cases now, and the early results are really encouraging. I'm going to show what we are doing. So we'll start with the first case we actually did in AIG. So this is a esophageal fistula. This is actually the 90 days from the onset of the esophageal defect. And this was due to a foreign body impaction and a transmural perforation. The foreign body was removed at a local place, but they placed an NG tube and treated with antibiotics, hoping the defect would close. But even after 3 months of conservative management, the patient presented to us with a persistent fistula. I hope you can appreciate the CT images showing the defect in the mid-esophagus. So I'll discuss the video of the technique of how we do the regenerative endoscopy. So even though the endoscopy paper has shown that they harvest around 30 ml, but we have started using around 80 to 100 ml of fat harvesting is being done from the thigh and the buttock region. In discussion with our plastic surgeon and with Dr. Valerio, we felt that the more amount of fat is better, and our plastic surgeons are really good and they give us good amount of fat in a very short period of time. So the first step is to harvest the fat. After injection of tumescent solution that contains RL and lidocaine, the fat is harvested. Now, once the fat is harvested, we do the mechanical emulsification by passing the fat through 2.4 and 1.2 mm filters. The step basically is done for two things. One, it breaks down the adipose tissue, the stromal factors are released. And number two, it also activates the mesenchymal stem cells because we need for them to be activated for us to have the regenerative and anti-inflammatory properties. So at least 20 to 30 passes are done through each filter. And then that mechanically emulsified fat is centrifuged at 3000 RPM for 3 minutes. Which gives us this beautiful 3-layered adipose tissue. And the middle layer is then collected, which basically is a true adipose tissue, which contains adipocytes, which contains the tissue stromal fraction. That is the TSVF. That's what was discussed in the study. And this is injected into the fistula site. So just to show the 5 steps, the first step is the harvesting of fat. The second step is the mechanical emulsification. The third step is the centrifugation. And the fourth step is the injection of the TSVF into the submucosally around the fistula or around the defect of the fistula. So we show you this brilliant result of the first case that we had. You can appreciate on the left-hand side the barium and the fistula endoscopic image of the esophageal defect. And on the right side, how the defect has completely healed. Even this was as early as 4 weeks after the injection. We wanted to wait for the 4 weeks for the first patient. So this is what we have seen. Complete healing, complete epithelialization. And I'm very happy to share the patients who have completed the follow-up. And 4 out of 5 patients who have completed the follow-up, we had complete closure of the fistula. And you can see we have a wide variety of cases: esophageal defects, intracutaneous fistula, gastropleural fistula, colocutaneous and rectovaginal fistulas. And the most importantly, none of these patients had any sort of adverse effects, be it related to the fat harvesting or related to the injection site. So we are really encouraging early results, and we are hoping to share our data soon.
Great.
Thanks, Gautam. Thanks. I think that was phenomenal.
Excellent.
Sir.
So I think we are in a new phase, I think a new dawn in endoscopy, regenerative endoscopy. So I think this initial results Gautam has shown is very important. Couple of small points. This is actually not mesenchymal stem cells itself, or they call stromal cells. Stromal cells itself, there's a lot of vasoactive factors in this part of the fat, which is also responsible. So I think there's a lot of work that Valerio and Ivo have done, published in basic science journals, which have shown that in addition to the so-called mesenchymal stromal cells, there are also a lot of vasoactive factors and also anti-inflammatory factors. We don't understand all of them, but I think that's the reason. Because initially we are trying to do bone marrow and then take stromal cells from bone marrow, but bone marrow stromal cells, issue is that you're only getting the stromal cells, you're not getting vasoactive factor. So I think this is a very interesting development. Couple of important clinical points are that the fat that is being taken from the thigh, usually from the thigh, sometimes abdomen, but the fat that's taken, the procedure should be done in the same room as endoscopy, because according to the regulations, there's a Indian cell regulatory body that's there. If you do it in some other room, then you're not allowed to, because the cells should not be transported. So it should be done in the same area. So you can't do it in your theater, take it out and then do it in some other place, endoscopy. This is one important. Second, I think it's very important to have your plastic surgeon do this. And we find that their expertise is so good in this because they're doing this for other reasons. So plastic surgeon has to do this. And there are very standardized cannulas and all that are available now, which are expensive, but I think can be reused. They're not all disposable. The third important point is regarding, I think Gautam showed very nicely, very high success rate. I think the reason why the rectovaginal or rectovesical fistulas will close if you have diversion. If we don't have a diversion colostomy and then do the procedure, they don't close. And that's why initial results from Ivo's cases were not very good, because they didn't do this. And the fifth important point is APC, as far as possible, should not be done. People have a wrong impression. Do APC and do this procedure, it will be more. No, APC should not be done because that causes more retreat. So that's the reason. So these are a few important practical points I thought I should discuss with this.
So without epithelialization, you're directly injecting.
Yes.
Okay.
Yes. So then, because of the vasoactive factors, they're growing very rapidly. And if the defects are very close, then you don't require to de-epithelize that area.
Right.
Just closes by itself.
Sir, one comment. If there is a healthy granulation tissue, without healthy granulation tissue, if there is this defect are very chronic, they are fibrotic or something, sir. If there is healthy granulation tissue, then most probably it will heal properly. Only stromal cell injecting, or can it be synergistic, sir, if we roughen the area or something we have done?
Yes. In fact, in the initial cases, Ivo and all did roughening, but they did not find that it caused additional. In fact, it seemed to cause more problem. That's why. So if the defect is very large, say 2 centimeters, then by injecting you're not getting it close to each other, then of course it won't. That's why some suturing is necessary to get it close to each other. So what this vasoactive substance does, it gets these stromal cells to start going trans-epithelial into each other, into the over the bridge there, and once a small bridge is formed. So what is very interesting is we'll have to see if you can actually combine this with a biocompatible material. We had seen that if you put a biocompatible material and then do the injection, then a large defects can be healed. So I think the whole new field which we can explore now.
Nagi, any study available in Indian scenario?
No. This is the first study that we have done. Actually, there are only 3-4 studies in the whole world literature. If you see, there are 3 published. The only 2 or 3 groups, one in Brazil and one in Rome, are doing this work. But I think it's very exciting, and hopefully it's not. I mean, the main thing is how we remove this fat and then process it. Yeah, that's very important.
But the esophageal, this one regeneration was done by Kulvinder Dua. That's a different technique.
Yeah, so that's different. That is a totally different technique that they use.
This is
Using
very
cell
active. It seems to be very simple. But again, how much we can reproduce this data, we have to see that.
Yes.
And no?
Yes, exactly.
This is amounting to mesenchymal stem cell only, no?
And the stromal cells, actually, they are misnomer called stem cells. They are not stem cells in that sense. They are not pluripotent. They're stromal cells. So the main function of mesenchymal stromal cells is an anti-inflammatory phenomenon. What is actually causing this activity in terms of bridging the tissue is actually vasoactive factors that are present in this part of the fat in the thigh. So the stromal cells are not like stem cells going and forming new tissue. This is different.
I think that is useful for the gap is very small.
Yeah.
The defect is a large defect, then
exactly.
Secondary
No, I think you do a little suturing to get the things together. But I've seen some cases with Guido where almost a very large defects have been closed. But the most important is diversion. If you don't do a diversion in the rectum, then it doesn't close. Somebody asked the amount of injection is 2 cc approximately into each area.
So Nagi, last time you were discussing that in Delhi, you're worried about the fat. You remember that? So that's one thing. Second thing, if you're doing in the same room, that means the nanofilters have to be in the same room.
Yes. You have to have it same.
Because everything has to be in the same.
Yeah, Indian regulation, they're very strict about this Indian Act that if you're transporting cells from one area to another area, then it is not allowed. And
thirdly, somebody should compare it with bovine patch, pericardial patch, as well as fistula plugs, the porcine collagen.
Yeah, I think that's a good idea. If you can use some biocompatible material plus materials, then it becomes very, very interesting.
Yeah, I had one question. I think, Gautam, what was the largest size of the defect? I mean, that again, because this paper said more than 5 millimeters, you're doing some suturing. I'm really wondering what was your experience?
So the largest we did was 12 sir, and that required 2 sessions. So
right.
We didn't do any suturing in our series, but we still had very good. This patient had an end colostomy. The rectovaginal fistula had an end colostomy. I think that really probably helped us deliver.
Okay.
I think it's a very important paper. I'd like to again congratulate the panel for choosing this paper because I think this is a new area and a very important paper that should sort of get the endoscopists thinking. We are usually mechanical people. You don't think too much. I think this is a paper that should set us thinking into looking at the basic mechanisms of tissue healing and so on. And this may be something for the future.
Right.
But this regenerative medicine will go into pancreas, liver, and everywhere.
Exactly. I think that's a very good point, SP. I think it's something that is going to go. Already there is some evidence for liver, but I think other areas also is going to go.
There is a question from the delegate attendees. So the patient who are undergoing circumferential ESD, suppose like this is like Barrett's, can this type of therapy be useful?
So the main reason for treating patients who have had circumferential resections, either Barrett's or in the rectum, is to prevent strictures. We don't know whether this will actually prevent strictures, but I think the Japanese, this is what again Kulvinder has shown, that Japanese have shown that cell culture plates, when they're put inside, they're shown to decrease the fibrosis and stricture formation. So this form of therapy is mainly for fistulas or openings or communication between two surfaces. So a different concept completely.
Yes.
I think, Nitin, there is no more question in the chat box.
Yes.
So once again, thank you, everyone. Thank you, Nageshwar sir. Thank you, TSC sir.
I think once again, I put it in record. The Golden Jubilee needs to be appreciated and recognized and applauded, and a good selection of cases. Thank you very much for the opportunity.
So thank you very much, sir.
Bye-bye.
And thank you to our audience. Thank you, Dr. Gautam. Thank you, Mishra, sir, to have you here. And thank you once again, sir. And looking forward to all audience to have our 51 edition next month. Thank you, sir.
Thank you.
This opportunity, with the permission of the chair, the next month, the ACG International Webinar, with the permission of chair, we are going to have a very interesting doctor and finance and doctor and entrepreneur. And who is the biggest entrepreneur of doctor in India? Dr. Nageshwar Reddy. So he is going to tell how you can be both academically strong, at the same time how you can be an entrepreneur, how you can wear a Modi jacket and attend the academic. That is a standing example.
Nagesh should be telling you the flip side also.
So don't miss it. 16th October, 7 p.m. to very exciting talk. Already I've seen 400 people have registered. So that will be a great meeting. Okay.
Thank you. Thank you, sir.
Bye.
Thank you, sir.
Thank you, sir. Thank you. Thank you, Gautam. Thank you, SP sir.
Thank you, everyone.